Welcome everyone for our Yetenaweg with EMA CME session. It's our first CME in this new year, and we would like to say Happy New Year as well. So, as you all know about Yetenaweg, it's a non-profit organization. It's registered in Pennsylvania, USA, and we've got nearly 150 active volunteers who participate based on their expertise, and we are around five different countries and counting more. So mainly our main area of focus with Yetenaweg is we work on health promotion, where we do health of general public and health policy implementation, working closely with Ministry of Health, and we do community engagement and blood drive activities. And as you have seen last month, during September 9 and 10, we prepared an event called Art and Health, where we tried to collect blood and also did fundraising, and we did try to reach to the society by volunteering, by giving them screenings and the like. So we've got another mentorship and skill sharing platform where there is going to be direct mentorship, one-to-one mentorship by anyone who is interested in their specific career path and soft skill, as well as professional development webinars. So the main part is the medical education. This one, for example, is a CME where we conduct continuous medical education so that everyone gets to participate and get a credit unit, 2 credit units for free, and that will help them update their license. And we have got our research in QI project. I'm going to show you some pictures about it. So we're more than a digital platform. We try to reach out the society. We try to give them education and the like, and fundraise. And as you can see from the picture, so we try to close the gap between health professionals and patients and the community, so that we could increase health awareness and working together. So there is it in our Roha and health article writing competition that was made a few months back. So what we do in the article writing competition is we make people to write health articles based on local language in Amharic, in Oromifa, and the best articles will be selected and given a prize. So as you can see, this was 2021 winner, and this one was on 2022, and the 2023 winners were announced virtually. So anyone who is interested in writing articles in local language, you'll be more welcome to join with us, work with us. So there is Yetenaweg Roha Research Fellowship Program, along with the Gurambesa Hospital, where we try to collect research topics, and so our winners were announced last time, and we got 2 winners from internal medicine and 2 from oncology department, as you can see them from this picture. So we gave them Roha with Yetenaweg and Gurambesa Hospital collaborated to fund this research fellowship program. So coming to our CME session, it's freely accessible. So we conduct twice per month, and it's freely accessible. So far, we are nearly 30 CMEs conducted, and minimum of 150 to 200 healthcare professionals join us. So right now we can see 105 participants that joined us. So in 2023, we plan to have focus on non-communicable diseases and current issues, mental health, and SRHR issues as well. So our CME currently is met with Ethiopian Medical Association. We also work with Ethiopian Society of Cardiac Professionals, as well as Ethiopian Dermatology and Venereology Society to give us this continued training so that we could upgrade our knowledge, and we invite renowned international speakers. So stay tuned and join us on our social media platforms. So the previous CMEs, you can find it on YouTube. If you can search Yetenaweg, and you'll be able to see the previous CMEs here. So to get updates about our upcoming CMEs, make sure to join us on Yetenaweg channel for professionals. We'll be sharing the link tree in a few minutes, and follow us on social media. So there are pre-requirements for our CME. So you guys are supposed to attend the whole session virtually, because we can see from Zoom how many minutes you attended, and make sure to fill in the form for personal details and attendance. And in the form, we're going to attach questions. So make sure to answer 50% of the post-webinar quiz, so that we can give you the certificate. And so you can see your results right away, but the certificate might take 1 to 2 weeks to be delivered to your email. So we'd like to ask you to patiently wait, and thank you. Let me introduce you our guest speaker. Today's topic is going to be on approach to acute limb ischemia with Dr. FERON GETACHEW. So Dr. FERON GETACHEW is a vascular and general surgeon who completed his undergraduate study at Addis Ababa University School of Medicine. He then pursued a specialty in general surgery and worked as consultant general surgeon at Saudi Memorial Hospital, and completed a subspecialty training in vascular surgery. Currently, he serves as consultant vascular surgeon and assistant professor of surgery at Addis Ababa University School of Medicine, the Columbus Specialty Hospital, and he also works in private hospitals. Apart from clinical roles, he has demonstrated leadership roles. At the beginning of his career, Dr. FERON has served as assistant head of outpatient directorate of the Columbus Specialist Hospital, and later he played a critical role during a design and implementation development of vascular surgery fellowship program at Addis Ababa University School of Health Science. He has contributed in different committees under CHS Addis Ababa University, and he has been advocating for better health care and society development in mainstream and other medias. Further, Dr. FERON is founder of Help Ethiopia civil society organization, which is a multidisciplinary organization that works in areas of health equity, charity, and quality improvement. He holds the position of president of Help Ethiopia since 2021. He's a member of different professional associations, including Ethiopian Medical Association and Ethiopian Surgical Association, and he has been a trainer of AP Initiative Simulation-Based Medical Education and Center for nearly 1 year, and has worked as master trainer at Lifebox Foundation. Dr. FERON's dedication to continuous professional development is evident through his completion of various trainings ranging from project management, quality improvement, epidemiology, and scientific and grant writing. Without further ado, I would like to invite Dr. FERON.
All right, so thank you so much again. So acute limb ischemia is an extremely important subject, particularly in our country, as we don't have vascular surgical service is limited in our setup. So vascular surgery service in general, not only for the care of acute limb ischemia, but other services are in its infancy in our country. And also most of our medical schools in the country, they don't provide dedicated vascular surgery training. So I think it's right if I assume that this is extremely critical for not only those that are engaged in training right now, but also for those who graduated before the establishment of vascular surgical services in the country. So this is important. So before I just dive into the topic, into acute limb ischemia, since this subject is, like I said, the service is new, I would like to take 1 minute from you guys and try to tell you what we do in vascular surgery unit. So we treat acute and chronic limb ischemia patients with peripheral arterial disease. Vascular trauma is also extremely common in our setup. So starting from neck injuries, abdominal injuries, and extremities in the upper lower extremities, we treat these conditions. Patients with chronic venous insufficiency, carotid body tumors, and also other carotid surgeries, and dialysis access, simple and complex arteriovenous fistulas, grafts, and others. We also commonly treat aneurysmal diseases, whether it's abdominal aneurysms or peripheral aneurysms. Less commonly, we also treat our colleagues in other subspecialties, either consult us preoperatively or we collaborate intraoperatively during advanced tumor resections, during abdominal surgeries or other surgeries. And also less commonly, we treat medical renovascular diseases that are resistant to medical treatment and also other conditions. So vascular surgery is a very wide topic. And acute limb ischemia is just very important as part of these other conditions. So the objective of this today's session is not to give you a detailed management plan for acute limb ischemia. From the responses that I have seen in the chat box, and also as the organizers told me, most of our participants are under training or general practitioners, primary care physicians. And I think this is also accordingly a basic approach to these patients. So we are not going to discuss the management of traumatic acute limb ischemia. That by itself is a very diverse and it needs its own discussion, and also treatment of acutely occluded bypass grafts. And it's again a further discussion, but for the interest of time, I will not be discussing those things. And also acute limb ischemia in pediatrics, which is not really common, but it needs something to mention. Most of these patients managed by medical therapy, but there are some indications for surgery. We'll not be talking about that. And the vast majority of our care relies on open vascular treatment because of resource and other issues. So endovascular, I will not go in detail on endovascular management. And also this is not, a discussion on clinical trials and other controversies in vascular management of acute limb ischemia. So this is the content of my presentation. So first we need to know what the risk factors and what causes acute limb ischemia. And then we shall see how patients clinically present to us, and then and what modalities that we have to use to diagnose these patients. And finally, we will discuss on the treatment options and then how we actually make a decision to treat these patients. So to give you a brief introduction, knowing the definition is very important. Acute limb ischemia is a sudden decrease in arterial perfusion of the limb. It can be upper extremity or lower extremity, but more commonly in the lower extremity, that when it poses a potential threat to survival of the limb. Sometimes it's possible without to have a sudden decrease in arterial perfusion, just giving you claudication without a threat to survival of the limb. So that can be managed as a subacute or chronic limb ischemia. But in acute limb ischemia, we are dealing with those who have, which can result in potential threat to survival of the limb, amputation, and other complications. And the time framework is also extremely important. So we generally classify those patients who present in 2 weeks as an acute limb ischemia. But particularly in our setup, patients can also present after 2 weeks. And we may use the term subacute in these patients when they come late because of when the condition is neglected and they present later. But it can also happen elsewhere. So what basically happens is, if you take this example, this image for instance, so the occlusion, the arterial occlusion can happen anywhere. It can be in the aorta or the iliac or the femoral segment or in the popliteal segment. So what happens is this segment, whether it's in the previously diseased artery with stenosed artery due to atherosclerotic disease, which complicates by plaque rupture, and then forms into clot may form, or in previously healthy patients without any arterial disease, particularly in those patients with cardiac disease, patients can have sudden onset of occlusion. So what commonly occludes these arteries is a thrombus or an emboli, so something that blocks the artery, and the distal segment of the artery, depending where the level is, the distal segment of that artery, that limb will be ischemic. So misdiagnosis is extremely common in our setup. Most of the times patients, they actually present to hospital late, but there is further delay in hospital because physicians usually attribute the condition to neurological causes or rheumatological or orthopedics and other conditions. So misdiagnosis is common, so understanding of this disease is very important and very essential. I'm not going to talk much about epidemiology because the local data about this is limited. Currently, we are with our colleagues, we are doing a study on the actual extent of the disease. At least in our hospital, short-term studies have been already done, but they are only limited to a couple of months. So I think it's more reasonable to talk about this afterwards. But generally, these are patients with advanced age or cardiac disease or with multiple comorbidities that usually present with acute limb ischemia. So why should we be concerned about acute limb ischemia? So what's the big deal? So the problem with acute limb ischemia is that patients usually, this condition is not only limb-threatening, but it's also life-threatening. And the mortality rate is really high, and the major amputation, by major amputation, we mean the below knee amputation and above knee, and also proximal amputations are generally categorized as major amputation, and that is really, the number is high. There is a recent study done in Sweden. This is a population-based study published in 2020 in Malmo, and their combined major amputation and mortality rate at 1 year was 46.6%. This is in the developed setup, and the same figure for those patients, I mean the same variable for those patients from nursing home on admission was close to 100%. So you can imagine what can possibly be the numbers in our setup. So I'm not saying this is a number all over the world, but this depends on multiple factors. But I think there is no any controversy that the significance is so high that in the damage it causes is really significant. And the disease is not only directly related with limb ischemia itself, but like I said earlier, these are patients with multiple comorbidities with the coronary artery disease, stroke, and have advanced age. Some of the patients have malignancy and the like. So all this together, it gives you, so these are patients who really need care, not only for the limb, but also for the patient as a whole. So the psychological impact, psychosocial impact in our setup is also significant. Most of our patients are younger than those patients who present in the developed setup. Some of the patients could be supporting their family, and the impact is so significant. The cost implication is also very high. So knowing the risks for this condition is very important, because when we find those patients at risk, so primary prevention can be done. And also once they have presented to you, then you can aggressively identify them and start management. So most of the patients, or at least a significant number of the patients, they will give you a history of chronic limb ischemia. So they tell you they have, pain during walking, which is an intermittent claudication. It can be at the most commonly at the calf level, but it can be also at the thigh or buttock level, depending on the site of occlusion. Also, this is not very common in our setup because the second one, the previous history of peripheral revascularization, but in those centers where there is a vascular surgery service, this is also an important history. Otherwise, atrial fibrillation, particularly in younger patients, even in our patients with endocarditis, in patients with valvular heart disease, cardiomyopathies, and the like, these patients also tend to develop an embolic acute limb ischemia. And further history will also tell you that these patients would have other comorbidities. So when we go to causes, the list is very long, but the most important cause, or the most common causes, are thrombosis of native arteries, embolism, and traumatic arterial injuries. So also, like I said earlier in the previous slide, after vascular surgery, patients can also develop the thrombosis of the graft due to kinking, twisting, or stenosis, or due to different reasons. So the commonest source of embolism is the heart. So patients can have mural thrombus in the heart, or cardiac tumors can be a source of embolism, aortic dissections. and sometimes also aneurysms where there is an intramural thrombus that can dislodge and to travel distally and block arteries at different levels. So this can happen at different locations, but commonly at the bifurcations. It can be the aortic or the iliac or the femoral or popliteal bifurcations or trifurcation. But less commonly, there are also other causes of vascular, acute limb ischemia. What I would like to emphasize in our setup is that trauma is an extremely important cause. So the prevalence of trauma as a cause of acute limb ischemia is very high when you compare to other sites because of conflicts and also high rate of road traffic accident. Both the military and civilian injury is responsible. So if you take this, this is a case that we operated. This is upper extremity injury. You see a thrombosed brachial artery. Luckily, the patient's median nerve is intact. So there are different treatment modalities we can employ for this patient. We harvested a vein and we did interposition graft, and the patient did well. And multidisciplinary care is also good. So this patient had also a fracture, and our orthopedic colleagues, they did exfixation. I'm not going to talk much about trauma because this is by itself a very vast topic and it needs a separate discussion. So I will not be further talking about trauma. The next is uncommon causes. I'm not going into the details. I know this is a very long list and a bit congested, but for the sake of completion. The commonest ones are what I have already said, but there are rarer causes of acute limb ischemia. It can be vasculitis, or in younger patients, popliteal entrapment syndromes can be there. Rarely paradoxical emboli in a patient who had a DVT that travels through a patent arterial septal defect and into the systemic circulation can be there. Tumor embolism from cardiac or lung tumors is also a possibility. Our orthopedic colleagues probably have seen this more commonly. They have the acute compartment syndrome. It can be due to trauma, or even in the absence of trauma, can be a cause of acute limb ischemia. During interventions or in IV drug abusers, foreign bodies can also travel and cause an embolization. Rarely, thrombophilia can also be a cause of acute limb ischemia. Thrombophilia is more of a cause for venous thrombosis, but arterial thrombosis is also a possibility in those patients who have antiphospholipid syndrome and other familial conditions. And this patient that you see here, this picture was taken in the ICU in the Rambessa in low cardiac output because of limb ischemia, upper limb ischemia because of low cardiac output syndrome. So this is commonly seen in those patients with shock or heart failure, and those patients on medications, vasoconstrictive medications like epinephrine and others. All right, so now the next important thing is, so we know what causes now acute limb ischemia. So the most critical thing is to be able to make a diagnosis on these patients. So to make a diagnosis, the most critical thing to do is not, requesting for a fancy investigation. It's rather to take a proper history, and making a diagnosis is not that difficult. So usually patients present with pain, they present with pain, but pain is not always the presentation, particularly in the acute aortic occlusion. Patients can present with just paralysis, and they could be sent to neurologists as a part of evaluation for a neurologic condition. But the vast majority, they present with pain. Pain is very severe, usually does not respond to the usual medications. And unlike like the rest pain of a chronic limb ischemia, the pain in acute limb ischemia tends to be more diffuse than the rest pain, but they can also present with rest pain. And the other is, of course, on your examination, because the trunk is occluded with thrombus, then the limb becomes relatively pale. So that's important. Another extremely critical thing to look for is pulse deficit or pulselessness. So pulse can be entirely absent, but not necessarily absent. Sometimes if there is a good collateral circulation, there can be weak pulse can be felt. So I think a better term to use is pulse deficit. So in the presence of pulse deficit, it's important to consider occlusion. The other is paresthesia. Patients may complain of numbness in their affected limb, upper or lower extremity. Usually the first sensory loss to be affected is a light touch and proprioception, but as time goes on or as ischemia advances, temperature can also be affected, pain, pressure, others can also be affected. So while doing a sensory examination, it's also important to do this earlier symptoms initially, then you can also grade later on. Another is paralysis. I think paralysis is somehow misnomer. I mean, for a patient to develop paralysis, it has to be really advanced ischemia. So maybe I think motor deficit or motor deficit, I think, is a better terminology. Patients usually they have, when they have advanced ischemia. Once a patient developed motor signs, it means that the ischemia is advanced. So you may ask the patients to flicker their toes or digits, and they will have difficulty of doing that. Initially, the first to be affected is the intrinsic muscles of the foot. But as the ischemia advances, the gastrocnemius muscle and the soleus muscles and the leg muscles will be involved. And when you palpate the patient over those muscle bulk, the patient could have, tenderness. Another important sign is coldness. When you touch the patient, it feels it's really cold. And all these features suggest a presence of limb ischemia, and particularly in acute limb ischemia. Other axillary examinations include capillary refill. Usually it's going to be delayed, or if it is irreversible ischemia, it may be also absent. So it's always important to compare both sides bilaterally. But like I said, bilateral involvement is also there. So if bilaterally absent, then that's obviously a serious problem. So primarily it's a physical examination, but if I know that this is not available in the most of centers in our country, but this handheld Doppler signal is a very crucial adjunct for the examination. You can try to listen to Doppler signals, arterial or venous signals using this. So generally, the patient's presentation depends on the level of occlusion. So for example, if the aortic occlusion, you will not find bilateral pulses at the femoral level. If it's only unilateral, for example, external iliac artery or femoral artery, then your finding will be, a bit distant. So that's how it goes on. As you go distally, then the level of involvement will be limited to segment of the extremity. So the patient's presentation depends on different variables. And before I make a comment on this, I have to remind you that you should not wait until all these 6 P's are fulfilled. If you find 1 or 2 of these findings, then I think it's very important to consider acute limb ischemia and try to elicit more history, more physical examination, and if necessary, physical examination. So that depends on the location and duration of arterial occlusion, like I said. Excuse me. So as the duration advances, patients will present with more profound symptoms like motor loss and the like. But if patients have, early ischemia, then you may not see those severe manifestations. Another important parameter is the presence of collateral circulation. Those patients who had previous history of arterial disease, the smaller vessels tend to get bigger, and then they traverse the occluded segment and they perfuse the distal segment. So the ischemia will not be that severe. At least it will give you time for intervention. Another, factor that may affect patient presentation is, the metabolic changes related to ischemia. In severest forms, when patients develop compartment syndrome, when they develop sepsis, patients can develop, acute kidney injury, hyperkalemia, and other manifestations can also be there. So generally, patients present in these 3 distinct categories: arterial thromboembolism, but there is also arterioembolism, but usually tends to be, a bit subacute or chronic. But in acute settings, mostly it's thromboembolism is one presentation. The other is acute on chronic limb ischemia, where patients have chronic history, but it becomes acutely exacerbated. The pain and everything will be severe. The other is during procedures, when cardiac interventions are done during femoral access or others, or when nurses secure IV lines, may heterogenically, injure arteries and the like. But like I said, it's extremely important to remember in our setup, trauma, non-iatrogenic or traumatic acute limb ischemia is also a very important presentation. This is a bit detailed, so I'll be very quick on this. This is a summary of what I have just said. So trying to differentiate between thrombosis and embolism is very helpful. So patients with thrombosis, by thrombosis, we mean that clot has formed in the target area, in the target artery. So this is usually in the background of a stenotic lesion. So patients will tell you previous history of claudication, and the presentation is protracted, usually days to weeks for the reasons that I've just mentioned, and the severity of ischemia will be lesser, and you'll see features of chronic ischemia, and you may expect also pulse deficit in the contralateral leg because peripheral arterial disease is sort of a systemic disease, whereas in embolism, usually the source is cardiac, but others like aneurysms or proximal arterial disease can also be a source of embolism. So otherwise, the target artery is healthy, so you don't expect previous history, and patients will have a profound ischemia because there is no collateral circulation, and the arteries will be softer, and you don't see features of chronic ischemia. And that can also be differentiated based on where you're doing angiography as well as duplex ultrasonography. All right, so again, this table may seem a bit congested, but this is extremely important table. This is Rutherford's classification of acute limb ischemia. So we base our decision primarily on this graph, on this table. So based on patients' severity of symptoms, after we did physical examination primarily, and also supported by Doppler signals, we classify patients' limb into a viable limb, a threatened limb, and irreversible limb. And the second category, or the threatened limb, can be further classified as marginally threatened and immediately threatened. This has an important prognostic value, and also it tells us the urgency of treatment. So what we basically do is we do physical examination. So we do sensory examination and we do motor examination. So what we call a viable limb is that the limb is not immediately threatened. You have time to work up the patient. You have time to do duplex ultrasonography or CT angiography. So when you do exam, you will not find sensory loss, or you will not find muscle weakness. And if you do Doppler signals, you'll find both arterial and venous signals. Whereas in the threatened category, in class 2A or in marginally threatened limb, the sensory function will be somehow limited, but it's only limited to the toes. It does not go beyond the toes. It doesn't involve the leg or the entire foot or the leg. And you don't find generally muscle weakness. And arterial signal can be inaudible, but definitely or most likely the venous signal is audible. The class 2B is called immediately threatened limb. By immediately threatened limb, it means that you don't have really time to work up this patient. You have to immediately revascularize the patient. You have to take the patient to the OR. And this is a really emergency. So if this patient presents at midnight or at any time of the night, you have to operate on that patient, or you have to manage him. There is no way you can postpone the surgery. Whereas in class 2A, you can do that. So in class 2B, or in immediately threatened limb, patients will have the sensory loss will be more than the toes, and they can have a rest pain over the foot. And muscle weakness is also will be present, and somehow there's going to be a moderate weakness. And arterial and venous signals are not expected to be audible, but sometimes venous can be audible. The last class is an irreversible limb ischemia, or a category 3. This means that whatever attempt you do to salvage the limb, that's not going to be successful. And when you do examination, the sensory loss is profound, anesthetic. The patients will not have any pain or temperature or pressure, any sensory function. And they will have paralysis, and the motor loss is profound. So the treatment is also for these patients, revascularizing this limb, attempting to save the limb is contraindicated because this attempt may lead to revascular ischemia reperfusion injury, which is a life-threatening condition. So by doing that, you'll convert the limb-threatening condition into a life-threatening condition. So that's very important. I'll talk about it later on. So there are others, other evidence that you can see. For instance, the color of the skin can be fixed. The cyanosis is not something that will come and go when you compress it. Rather, it's going to be fixed, and that's also a sign of somehow irreversible ischemia, and there will be muscle rigor and the like is suggestive of irreversible ischemia. So in such patients where the gangrene is clearly demarcated, it's not difficult to make the diagnosis, but not all patients will have this feature when they present. So some of you may wonder if there any laboratory or any other means of telling which patients may benefit from revascularization or which patients have good prognosis or the like. However, these parameters like creatinine kinase or C-reactive protein of greater than 49, a neutrophil to lymphocyte ratio of greater than 5 has been suggested as a poor prognostic sign by different researchers, but this is not well established. And for these things to rise significantly, that by that time, patient has already advanced ischemia. So it's not recommended to rely your management on any of laboratory markers, but rather by the examination that I've just mentioned earlier. All right, so now we've clerked this patient. We have taken history. We did physical examination. So for the vast majority of patients, then we know that this patient has a limb ischemia. So it's very crucial to understand that. Then sometimes we may need to do imaging modalities for different reasons, particularly in the class 1 and class 2A, because that will give you a time for investigations. For those advanced ischemia, for class 2B, like I said, you don't have time to do those things. So the benefit of this is, particularly in those patients with background disease, then it tells you what you have to do other than thrombectomy. You may need to do further management. So as a surgeon, you will be more prepared in dealing with this condition. So I think the most easily accessible in most centers and very easy to do is duplex ultrasonography or Doppler ultrasound combined with B-mode imaging. So this is a machine as you know it, and this is a B-mode imaging of femoral artery. You see the common femoral vein. It's clearly, there is no any content in here, but if you see the common femoral artery, there is an echogenic content. I hope you can see it. And if you do a color flow, you see the venous segment, the saphenous vein entering into the common femoral vein. However, this common femoral artery is not visible at all. It's supposed to show color, red color, but since it is filled with this echogenic content, you don't see it. There are also other things that you can do with duplex ultrasonography, but I'm just mentioning the basics. So you cannot, if the ultrasonography tells you that there is no acute limb ischemia, you cannot rule out acute limb ischemia. Like I said, your diagnosis is primarily clinical. So we cannot entirely rely on duplex ultrasound. It's only adjunct to your diagnosis. So it's less reliable in tibial arteries, but tibial arteries alone are not really cause of acute limb ischemia by themselves, unless all the three are involved generally. This is also the problem with CT angiography. So next, and the most important that we do, particularly in our setup, is CT angiography. CT angiography, we more commonly do it for chronic, but like I said, for those patients who doesn't have advanced ischemia, we sometimes prefer to have CT angiography because it tells you more detailed information. You can see it, you can map the anatomy, and you can plan treatment. So as you can see it on this image, you can clearly see the embolic occlusion without any collateral circulation. So this is an acute occlusion, acute thrombosis or embolism. I mean the embolism, but you can see the healthy segment. But this is not the only view. You can see a different views and more detailed information. Also on CT angiography, you can do chest imaging. You can see, for instance, on this image, you can see that cardiac thrombus as a source of an emboli for the distal acute limb ischemia. And thoracic, the thorax can be imaged, abdomen, and not only the vascular tree, but you can also see other other conditions. Again, this is also poor in tibial evaluation, but for the tibial evaluation, the digital subtraction angiography is preferred. This is another image of CT angiography. As you can see it here, you can clearly map, the patient's arterial tree. On this patient, you can see everything is fine on the contralateral side, but on the right side, there is basically no flow to the distal extremities. This patient ended up with amputation because she presented very late, and the ischemia was very profound, and the popliteal thrombus has also poorer prognosis. This is another image where you can see, aortic occlusion. This is because of the saddle emboli. So also in situ thrombus can also present like this. And after thrombectomy, the thrombus has been removed, as you can see it here. So CT can clearly show you the problem. Another, what we are not doing commonly is the digital subtraction angiography. This is standard of care in many centers. Particularly, it's important when you are considering therapeutic endovascular interventions. So again, here you can see, a chronic plaque on the arterial tree on this image. Here you also clearly see collateral circulation, suggesting that there is a background arterial disease. And also you can see somehow, excuse me, embolic occlusion with stasis of contrast. Also in the other image, you can clearly see this is a popliteal area. The filling defect can be seen on imaging. This is a summary of what I have just said based on their availability, accuracy. Maybe what I haven't mentioned is the magnetic resonance angiography, MRA or MRI. So MRA, we don't use it here commonly. It takes time and it's not available. The expertise is also very limited. All right. So now we made a diagnosis. So we know how patients present. We know the causes. So we worked up our patient. Now, the next thing to do is, as I have seen, most of you are primary care physicians and also other specialists. So what is the initial management before we engage the vascular surgery team? So patients will have really severe pain. So the pain does respond with the usual medication. So analgesia is very important. These patients most likely will end up having surgery in our setup or other interventions elsewhere. So, so doing this CBC cross-match and preparing blood, renal function test, as you are going to also might image these patients, and also in endovascular because contrast can be injected in these patients. The other is coagulation profile because you have to initiate these patients with heparin, and the efficacy or the success or the target, it depends on the APTT level that we have. So this has to be determined initially. So it's much better for the vast majority of patients when you diagnose acute limb ischemia to initiate them with unfractionated heparin. Usually we load them with 5,000 international unit IV loading, and then we don't have infusers here. Some centers, they do infusion. But here, the common practice is we usually put them in bolus subcutaneous doses. We also give them heparin during surgery, intraoperatively, intraarterially. So you have to give them hydration, fluid, oxygenation is very important. It improves limb survival. And positioning, the limb has to be, should assume a dependent position so that the blood supply can be, facilitated due to gravity. And early consultation is very important. This is something time sensitive. You should not delay these patients. That's very important. And frequent evaluation is also important. The patient that you classified as lower grade limb ischemia may deteriorate. So it's important. So depending on indications, you may need to do EKG or echo. That depends. That should be done, I think, after discussion with the personnel who would provide definitive therapy. So our treatment selection depends on multiple variables. So we have to weigh between the benefit and harm. There are some patients who may not benefit from intervention. For instance, patients may, with advanced malignancy, with a very limited lifespan, may present with acute limb ischemia. So those patients may not really benefit from aggressive treatment. And there are also some patients who are not ambulating, they are not using their limbs, but they have also comorbidities, and doing, or they may require complex procedures, and doing that may pose a threat to their life, and so on. So there are some complex issues that needs to be discussed with the family. Family and the patient should be counseled. Sometimes patients may, may complicate. So even after therapy, so may lose their limb. That has to be clearly communicated in a compassionate and sympathetic way, because most of our patients are scared of amputation. And like I said earlier, sometimes that's a definitive therapy. So all these things should be kept in mind. And patients' overall medical condition should be kept in mind. Their general fitness should be kept in mind. Sometimes you may need to choose. Most of the patients we do under spinal anesthesia for lower extremity, but if they are really frail patients, you may also need to do it under local anesthesia. For upper extremity thrombectomy, we usually do it under local anesthesia. So all these things should be kept in mind. The duration of presentation is what I have already mentioned. And the experience of the surgeon or the treating physician is also important while selecting treatment. So who has better experience in endo may attempt in the vascular, but in our setup, most of us have a better experience in open surgery. The other is, of course, the severity of ischemia. So maybe you may not remember this classification that I have just mentioned. The Rutherford class is very important. So those patients with class 1 ischemia can at least wait with anticoagulation. If they are, like I said, dying patients, maybe that's the only thing that you may provide. But for fit patients who have reasonable estimated life, then even those patients may be treated. So revascularization can be done on elective basis on those patients. However, in advanced ischemia, you have to do it immediately, like I said. And the other is the duration of presentation. So if they present in 2 weeks, percutaneous endovascular is preferred in the developed setup because when it's done when the thrombus is fresh. However, after 2 weeks, it becomes more organized, so it's not going to be amenable for endovascular fibrinolytic therapy. But for us, still for all this, we tend to give them open surgical options. So what do we do? Now we diagnosed, we manage them medically, we discuss with the family. The next thing to do is the definitive therapy. So the definitive therapy, the most common in our setup is surgical revascularization. So we have different options. The commonest that we do is thromboembolectomy. I will discuss what it means. Rarely endarterectomy can be done. And when thrombectomy fails, we may also, do bypass and bypass procedures. And elsewhere where they have both endovascular and open setup, they may also do hybrid procedures. I will discuss what I mean by this. So this is a treatment choice that we have. This is what I've already said. So as you can see it on this image, this is patient's abdomen is towards the right here. Patient's leg is towards here. And this is a common femoral artery. There is a profunda femoris and the superficial femoral arteries. So what we do is we secure all these branches, and there are tiny branches are also secured. And what we do commonly is we put a clamp. Before we do this, we give IV heparin, and then we make a transverse arteriotomy, or we cut the artery. And if the site of the thrombus is here, as you can see it here, this dark object is a thrombus. So it will come out. I mean, you'll see it. So what we do is we use a Fogarty catheter. This is a Fogarty catheter. And it's a long catheter. So there is a balloon here. When you insert it, you do not inflate it. You insert it in here when it's deflated, and then you inflate it using this side by a normal saline. So what you do is you insert the catheter and inflate it. So the tip can be inflated. You inflate it with saline, and you advance it proximally, and you pull it downwards. So it will bring the thrombus, and then there will be back bleeding, significant back bleeding from the proximal as well as from the distal segment. You should do the same procedure to the distal segment. And then you have to, this is what happens after you removed your thrombus. So we do this at least twice after, the whole thrombus has been evacuated. So how do we know that it's everything is out? So it's difficult to be sure without completion angiography. In the base setup, they do completion angiography. They image, they do imaging. As you can see it here, initially there was occlusion, but after they did thrombectomy or thrombolysis, then you find that artery is open. This should not be limited here, but you have to see it until the distal or pedal branch. So that tells you if your procedure is complete or not. Intraoperatively, we see significant back bleeding. You cannot rely on that, but it gives you some clue. But sometimes after you did your embolectomy, there is still residual thrombus. So you have to do your thrombectomy. And if there is a chronic occlusion, you should do bypass. And if it is sometimes also in the base setup, they also do thrombolytic agents in their hybrid OR. What we basically do is, since we don't have all these things, we do clinical evaluation and we look for pulses. And when there is Doppler ultrasonography, then we look for Doppler signals. But the reliable one is a completion angiography, as I have said. But for those patients that has a chronic occlusion, thrombectomy will not be adequate, because only the Fogarty will burst and it will not bring out this chronic occlusion, because it's well formed, it can be calcified, it's not possible to remove it. So what we do is, if it is a short segment occlusion, then we do endarterectomy, which is you make an incision on the artery and then you remove the plaque and then you patch it. You take a vein or a prosthetic graft and then you sew it with the artery, so that if you do primary repair, the artery will be stenosed, but you don't want that, so we do patching. But this is rarely done in acute limb ischemia. So this is a patient for whom, actually this is a picture from a chronic limb ischemia for whom we did an iliac endarterectomy. But for those with long segment occlusion, endarterectomy will not be reasonable. So what we do is we do bypass. So we harvest a vein from patient's ipsilateral side. If that's not available, from contralateral side, there are also other options. So we bypass it from the proximal patent segment to the distal patent segment. So patient will have a new pathway for the arterial flow. So the distal segment will get access to the blood supply. I hope you can see the picture on this side. This is an intraoperative picture of a patient for whom we did femoral TP trunk bypass. So this is a knee, here is the leg. So this is a vein, the autogenous vein that we harvested from this side, using skip incisions to facilitate wound healing. So patient will have new pathway for the blood supply. All right, so other option is, particularly in the better setup, is endovascular options. So thrombolytic therapy is other option for those who present earlier in 2 weeks. So what they do is basically to introduce a catheter using angiography, and it has a side walls, and you place it in the clot, and then so through these side walls, plasminogen activators will be introduced. Commonly used agents are urokinase and recombinant tissue plasminogen activator, but there are also other third generation plasminogen activators. So what it does is plasminogen will be converted into plasmin, and plasmin has the effect of cleaving the fibrin polymer, and that results in the dissolution of this thrombus, and then the artery will be clearer. So that will result in clot dissolution. So this is catheter-directed thrombolysis. And the other advantage is you may see those underlying conditions after thrombectomy or after this catheter-directed thrombolysis. If something is remaining, if there is endovascular setup, then you can stent it, or if there is no such setup, then you can do bypass procedures. So usually, as I've said, this is for milder patients and those patients with thrombosed bypass grafts for more than 30 days, if it is an autogenous graft. If the graft thrombosis occurs in less than 3 days, 30 days, usually it's because of technical, then maybe doing surgery may be beneficial. But this pharmacological thrombosis, thrombolysis is also not without a problem. Patients may develop stroke or significant bleeding, as you can see it here on this patient who undergone successful thrombolysis, but there is significant groin hematoma due to bleeding. Other than catheter-directed thrombolytic, others are percutaneous mechanical thrombectomy. In this case, what you do is the device will be introduced endovascularly and mechanically will break down the thrombus, and it will be removed. The other is for softer ones. There is also other option, which is an aspiration embolectomy. The device will be introduced and it will be aspirated, so it will take out the thrombus. This is without opening the patient. The complications can include distal embolization. All right, so we are approaching to the end of the session. So after you treated the patient successfully, you cannot just go and sleep. Complications may arise, particularly when patients present to you with delay, and the ischemia is really advanced. So what happens is you have ischemic limb, and the muscles in that muscle compartment in the leg. This is commonly in the leg, but it can also happen elsewhere. So you perfuse the limb. These muscles have been ischemic, so the reperfusion of these arteries will result in release of cytokines, inflammatory mediators, and oxygen-free radicals, and other toxic metabolites will be released. So what will happen is there will be vasodilatation and capillary leakage leading into edema. So the limb will become edematous. And the problem is there is tight fascial closure of the different compartments of the leg. So there is no space to swell, and patient will have severe compartment syndrome. So unless you diagnose it early, unless you reevaluate patients, if you miss the diagnosis, then patient will definitely lose limb, and or at least they will develop ischemic contracture. And the much worse problem is patient may develop systemic complications leading into even this and renal failure and cardiac toxicity. Myocardial injury can also be there, and these patients really require ICU care. So in our setup, the diagnosis is primarily clinical, but in the other setup, they have also these devices to measure compartments. So what is best thing to do is to try to prevent compartment syndrome. It's not always possible to prevent. So what we do is when patients have risk factors for the development of compartment syndrome or reperfusion injury, which is when they have prolonged presentation more than 6 hours, or they have hypotension, or they have severe ischemia such as Rutherford class 2B, and the like. So if all these features mentioned here, young age, for instance, because they have too much muscle mass, they are at risk of developing compartment syndrome. So in these circumstances, we tend to do prophylactic fasciotomy. So before the compartment syndrome starts because of reperfusion, we make an incision. So what we basically do is we do double incision, one on the medial side, the other is on the lateral side. So from the medial side, from the lateral incision, then we decompress all the 4 compartments of the leg should be decompressed. So we could decompress the anterior compartment, the lateral compartment, the deep posterior, the deep posterior, and the superficial posterior compartments should be decompressed from the lateral, the anterior and the lateral. From the medial incision, the deep compartments will be decompressed. So if patient has already established a compartment syndrome, as you can see it on this image, it will bulge immediately when you release the fascia. So this is very important. The multidisciplinary care can be relevant. Anesthesiologists are crucial in the management. Hydration is important. Management of acidosis is very important. Patients may develop AKI, and they may need dialysis. So you need everyone to manage on this patient. This is the last segment of the discussion. it's upper limb ischemia. I think the upper limb ischemia, the diagnosis is more or less similar, but there are tiny differences. Usually this, again, the diagnosis is clinical, and this is commonly seen in older patients. And most of the patients in the leg ischemia are limb threatening, but in the upper limb ischemia may not be limb threatening. I'm not saying they will not give you limb loss. They will definitely give you limb loss, particularly if they present with advanced ischemia. This is a picture that is one of the ischemic patients. But for most patients, it may not be limb threatening, so anticoagulant will improve for most of them. But the problem is the function of the limb will be limited. So the most common cause is embolism, cardiac origin, about 80–90% of the cases. So if patient's limb is threatened, urgent revascularization is definitely indicated. But it's not that much limb threatening, or in all patients, you have to keep in mind that the function of the limb can be in jeopardy, so still management is more recommended. And patients can also develop ischemic contracture. So what we do is, in arm ischemia, is that the thrombectomy is usually done using cubital incision with local anesthesia and probably with sedation, because when the catheter passes, patient can have pain. So if patient has, causes can be atherosclerosis is not a common cause in arm ischemia. Like I said, it's an emboli is more common, but rarely thoracic outlet syndrome can be a cause, and other rarer conditions, subclavian stenosis can be, or aneurysm with thrombus can be a cause of limb ischemia in the upper extremity. So I think it's important to keep these things in mind. So in summary, time is limb. This is limb-threatening and life-threatening condition. So, urgent diagnosis is very important, and early initiation of treatment is very important. And if there is a need, early transfer is very important. If you delay, patient will lose his limb and life. And it's treatable if they come early. So public education is also important. If they present early, then it can be managed promptly. But still, like I said, some patients still may have a poor prognosis. That's also important to keep in mind, and to counsel families. And another important thing to keep in mind is a diagnosis is not using different investigative modalities. It's rather clinical primarily. Those things, other investigations are adjunct to your diagnosis. And initial treatment should be initiated, like heparinization, as early as possible, unless there is contraindication such as recent stroke or massive upper GI bleeding, and like anything, unless there is something that contraindicates heparinization, patient should be on heparin and other supportive management that I have mentioned. And the other is, of course, you have to early engage vascular surgeon for the treatment to provide a definitive therapy for these patients. And also it's important to know different modalities of treatment so that you can also discuss those with your the family. These were my references. Thank you.
So I'll proceed with the first question. The first question reads, what is the role of aspirin and statin in acute limb ischemia?
All right. So thank you, all the participants. So regarding this question, and I didn't know that Professor Milliard was attending, and that's also really nice to hear. So thank you for your comments. And as it has been said, it's possible that we can, present those issues in the future, as they are very vast topics by themselves as well. So regarding the value of aspirin and statin, aspirin should be initiated. And if patient has been already on aspirin, it should not be discontinued just because patients will undergo a vascular surgery. Like I said, most of the patients will also have comorbidities. Either they have the diabetes or coronary artery disease or others. So generally, I think it's a good idea not to stop, or if they were not on such aspirin or other antiplatelets, then they should be initiated, or if they were, they should be continued. Okay.
Thank you, Dr. Farwa. The second question reads, Can you point out the vascular treatment for a patient with an acute compartment syndrome? What is the time limit and when it is not possible to revascularize? For example, in a pediatric patient with a missed compartment syndrome, since we are encountering bamboo splinted for simple fracture, that is leading to a missed compartment syndrome.
Regarding traumatic injuries, like I said, it needs a separate discussion because it's a very vast topic. But coming to specifically to compartment syndrome, the recommendation is the fasciotomy should not be delayed more than 2 hours after you've made a diagnosis. So as the time goes on, the success of your fasciotomy will fail. So if you delay it for about 36 hours, then it's pointless. Rather, what it would result is patient will have infection from your fasciotomy wound and will have sepsis and other complications. So fasciotomy should be done as early as possible. Both in traumatic cases, again, the recommendation there are risk factors for that will change, such as combined arterial and venous injuries and crash injuries, and when it's blunt injury and the like, the risk of injury, the risk of compartment syndrome will increase. So the message should be as early as possible. So you can even do it at your own center. Regarding pediatric age group, I have excluded that discussion because it's somehow a different group. The commonest cause of limb ischemia in pediatric age group is iatrogenic injury during umbilical catheterization or other sorts of injuries. In the pediatric age group, particularly the neonates and small children have better ischemia tolerance than adults. And most of the patients, because for most of the patients, what we do is we manage them with anticoagulants, but when it's associated with correctable surgical pathology, then surgery can be considered in traumatic conditions, particularly in older children. So I'm not sure if I have addressed your question. Is that clear?
Yes, that was excellent. Adail, can you stop sharing your screen, please? We can see only the, yes, thank you. So the next question says, can you tell us the role of aspirin in acute limb ischemia and the role of statin? Yeah.
I just responded to that question, I guess. Yes, there is a role for aspirin. Aspirin should be continued if patient was already on aspirin. And if the patients were not on aspirin, then it should be part of your initial management. Patients should be on aspirin, definitely. And statins also will benefit because particularly for those patients who are underlying diseases, including chronic claudication or other other diseases in other vascular beds, including coronary artery or other diseases. So generally, it's good to put them on such antiplatelet drugs.
Thank you.
Thank you. Yeah, you can proceed, Tadej.
Okay. The next question reads, how do you see doing fasciotomies after vascular repair? And is it a must?
Well, again, thank you for the question. Like I tried to say it earlier in the presentation, it's not always a must. Fasciotomy is not without a problem. So for instance, if you take patients who came early without any delay, or if patient was not in shock, or if it's, for example, older patient who doesn't have too much muscle mass, these patients may not really require fasciotomy, whether prophylactic or prophylactic fasciotomy is not indicated. Fasciotomy is not what we do routinely. It should not be done routinely. It is something that you have to individualize. So you have to do fasciotomy prophylactically if those risk factors, such as class 2B limb ischemia, is there. If the patient has significant muscle mass, if there is significant delay in the treatment, and the like, then you may need to do prophylaxis. Otherwise, in others, you have to frequently evaluate those patients, and then you may need to do a therapeutic therapeutic fasciotomy if you see evidence of compartment syndrome. So not for all patients, only when it's indicated. And does it help? Yes, it really helps. It's really life-saving, or at least limb-saving when it's done as per to the proper indication. And it needs also experience, to do fasciotomy to to dictate for which patients may I do or for which patient I should not do. But this decision is guided by these factors I have just mentioned now and also on the previous discussion. Thank you.
Thank you. So the next question reads, what should we use instead of ultrafractionated heparin for patients with contraindications?
So what shall we use? I think this is again a difficult scenario. If patients have contraindications for heparin, limb is not when patient is in life, when patient's life is at stake, we cannot prioritize limb over the life of the patient. So if initiation of anticoagulant would risk patient's life, if it results hemorrhagic stroke, and if results in upper GI bleeding or other sorts of complications from heparinization, then you can just simply put the patients on aspirin, and you can hydrate and just continue with other managements. Does it have a problem? Yes, but you are in a difficult situation. It's not something that you want to be, but you will be forced to avoid heparin. Regarding unfractionated heparin versus other sorts of heparin, commonly what we use is unfractionated heparin. If you have to reverse, you can easily reverse it, and it's easily accessible, and its monitoring is also easier and the like. So we tend to do unfractionated heparin. But in the presence of contraindication, then what I just said, I think holds true. Thank you.
Thank you, doctor. We have a few questions remaining. So another question reads, why is duplex ultrasound in CT angiography less reliable in the tibial arteries?
I think the radiology guys can better speak about the imaging modalities. But what is better is, like I said, if you take, for example, ultrasonography, the arteries become smaller, right? The tibial arteries become smaller and smaller. And there is also a muscle bulk in those areas. There is also bone, right? You have the tibial bone and the fibular bone. So the size and particularly in the presence of edema, things will be more difficult to assess. And it's also operator dependent. So the challenge will be much worse in the tibial vessels. The same thing goes for CT angiography. This has been established in many different studies. The yield from infrapopliteal imaging. So if you want to look for infrapopliteal imaging, what's best to do is the conventional angiography, not CT or duplex ultrasonography. But the importance of this discussion is when you are considering, one is to know burden of the distal outflow segments. The other is when you are considering bypass procedures. So you want to see if there is any vessel accepting your bypass. If you can land on your outflow vessels, this is also relevant, particularly in the chronic limb ischemia, but also in acute limb ischemia. I try to show you a picture where you cannot see at all the distal outflow. So the point I'm saying is there are some different accusations that they do, the radiologists, to enhance its accuracy of the CT angiography in these distal segments. But like I said, it's not really reliable. But when it comes to only a single vessel from the tibial vessels involvement, like I said, it's not going to be that much limb threatening. So when they all are involved, that it's going to be limb threatening. Thank you.
Thank you. So we'll just go over a couple of questions and we'll wrap up the Q&A. So another question reads, prior to surgery, how do we proceed with anticoagulants therapy?
Okay, so this is also a very important question. Again, I've mentioned this during the presentation. Unless there is contraindication, it's much safer to initiate patients with therapeutic anticoagulation as early as possible. And if there is, like I said, if there is any need to reverse it, can be reversed, but most patients, they may not require that. The benefit of heparinization or anticoagulants is that, one, it will stop the further propagation of the thrombus. That means the thrombus that has already happened will not bulk up and increase, so that the limb condition will not get worse. It has also anti-inflammatory effect. So heparin should be initiated. Generally, what we do is, like I said, 5,000 international unit IV, and then we do, so depending on where you are, you can do the continuous infusion versus bolus can be continued on such patients. And then what you want to achieve is the PTT value should double. That's your target. If you don't achieve that, then you are not properly anticoagulating the patient. So start them as early as possible, unless there is contraindication, is going to be the advice. Thank you.
Thank you. This will be the last question for the Q&A session. So the last question reads, what is the prognosis of traumatic acute limb ischemia?
This is the last question, but this is a very broad question. So like I said, I will be very happy to have also another, webinar on traumatic acute limb ischemia. That's why, I skipped it from the outset, because it's a very, very broad topic, and the approach that we follow and the surgeries that we do are also, variable. So I would be very happy to talk about that as well. But for now, what I will tell you is it depends. It depends. The outcome depends. If patients have doesn't have what's the injury, depends on what the mechanism of the injury is. For example, if it's a blast injury or crash injury with multiple segment involvement, then obviously you would expect that poor outcome. If patients, again, if they are delayed to your treatment, clearly that because the limb will be ischemic and maybe irreversible, they may come from the outset. So it depends. And again, that's different for upper extremity and the lower extremity. So otherwise, for stab injuries, for instance, patients come to your vascular center early, then and most of the patients that we have operated are young patients, whether in military or civilian setting. And those patients who come early, I would say that the outcome is excellent. Most of the patients, they will do. But it's important to keep in mind that other factors are very crucial. So not all patients will have, it's not going to be possible to salvage the limb for all patients. So the other factors will be, the development of compartment syndrome and the presence of combined arterial and venous injury. There are also other different factors. If patient was in shock, there is also, there are different scores, mangled extremity score. There are also other scores. They have their own problems and advantages. So like I said, this is a very broad topic. So I think it's better to discuss this maybe some other time with a different webinar. Thank you so much.
Dr. Feron, thank you very much again for giving us your time.
Thank you so much for hosting me, Dr. Zaka and Dr. Tadail. And I also would like to thank all the participants for their active participation and for the whole session. Thank you so much.